Welcome everyone. Thanks for joining us for today's webinar, GLP-1 Physiology and Evolving Clinical Data on GLP-1 Receptor Agonists. My name is Megan Shelley and I'll be your host today. This webinar is presented by ADCES in association with AstraZeneca U.S. Medical Affairs Cardiovascular and Metabolic Diseases Division. This webinar is educational in nature and contains no promotional or product information. There is no continuing education credit for the webinar and handouts will not be distributed. If you would like to ask a question during the presentation, you can type it into the Q&A box on your screen at any time and we'll answer as many questions as possible during the Q&A session at the end. I'd like to introduce Dr. Curtis Triplett. He's a Certified Diabetes Care and Education Specialist and Associate Professor at the University of Texas Health Science Center at San Antonio. So I will turn it over to Curtis to get us started.
Well, thank you so much, Megan. Welcome, everyone, to this exciting webinar that we have planned for you today. I think you're going to enjoy it because today's webinar will provide an overview of the actions of GLP-1 receptor agonists in the body. We're going to talk about some of the clinical effects of GLP-1 receptor agonists on glycemia, of course, for major adverse cardiovascular event data, CVOTs, cardiovascular outcome trials, and some of the renal endpoints that were clear in some of these trials. And of course, on top of that, we'll be talking about some of the metabolic effects, such as weight, etc. So and I think that's going to help you kind of solidify in your mind where GLP-1 receptor agonists may fit into therapy. And we're honored today to have a presenter, Dr. James Ruggles, who's an executive medical director in the cardiovascular and metabolic disease divisions at AstraZeneca. It's my pleasure now to turn it over to Jim.
Thank you so much, Curtis. It's my pleasure to be back here and presenting this to you. And before we get started, I just want to thank Curtis for all of his time and help with this talk, coming up with discussion questions and also looking at this data with me. So as we move through here, I just want to show this slide. All this material is intended for your medical education purposes only. And so, please don't take pictures of these slides or use these slides elsewhere. Today we're going to go over a brief review of the role of incretins. We're going to talk about glucose homeostasis and the role of GLP-1. We're going to look at GLP-1 receptor agonists specifically for the treatment of type 2 diabetes, looking at a lot of the key clinical effects of the currently marketed GLP-1 receptor agonists, of which there are many. Then we're going to look at GLP-1 receptor agonist actions beyond A1C, really looking at MACE and renal endpoints. And then we will look at GLP-1 receptor agonists and their effects to maximize effects on body weight. So let's start by looking at diabetes. Now this figure really depicts the natural progression of type 2 diabetes. I want to orient you to this graph. So at the top part of this graph, you're looking at relative amounts, and you're looking at insulin resistance in purple, insulin level in blue, incretin effect is the orange line, and beta cell function in the yellow. And then the bottom part of the graph is looking at glucose concentrations. And it's really breaking these concentrations out by post-meal glucose or postprandial glucose and fasting glucose. Now, as you know, early on in patients who have prediabetes, they manifest with insulin resistance. However, we still have quite a bit of beta cell function. And so the beta cell is able to compensate for this insulin resistance by increasing the secretion of insulin. And for quite a while, many years in fact, glucose levels are maintained in the normal range, as you can see down below. However, as insulin resistance continues to climb and becomes maximal, beta cell function declines, incretin effect is declining. Well, now the beta cell can no longer match that high level of insulin resistance. And so insulin levels actually start to decrease. At this point, the patient has impaired fasting glucose, okay, and as beta cell function and incretin effect continue to decline, they actually manifest and are diagnosed with type 2 diabetes. Now, interestingly, at the time of diabetes, the time of diagnosis, 50 to 80% of the beta cell function is actually lost. Now, when did they start losing this beta cell function? Well, actually, Rory Holman looked at this in the UK PDS trial. He looked at beta cell function and extrapolated backwards and showed that actually beta cell function began to be impacted 12 to 15 years prior to diagnosis. So, this whole process is starting a decade or more before patients are diagnosed. Curtis, do you want to give a perspective about what this means when it comes to treating patients when you actually do identify them?
Yes. Hold on one second. So one of the things I think is important to understand is that we clearly know that treating early has long-term benefits. So, I mean, if we just look at glycemia, for example, anytime the sugar goes high, it's clear that the body remembers that high sugar. And so what's happening is that long-term, some people call this the legacy effect, some people call it metabolic memory. The body's remembering that, and this is why we have some people, even in what they call quote-unquote prediabetes, that have retinopathy. And so we need to remember from a glycemia aspect, treating early and aggressive makes a difference. Also, this can make a difference on how long your medication may work. So there's clear data with metformin showing that the earlier and more aggressive you are in using it in patients, the longer it seems to be able to control glycemia. And of course, we think of metformin kind of as not a super great drug for keeping our beta cells working long term. But the bottom line is that even in that medication, it seems to matter how early and aggressive we treat. So I think just from thinking about it from a type 2 diabetes is a metabolic problem and glycemia problem, it's important for us to understand that early aggressive treatment helps our patients in many ways.
Great. Thanks, Curtis. So one of the questions, is, well, we're showing here this incretin effect, but really what is the incretin effect? And the incretin effect is really best demonstrated in this study by Michael Nauk et al. So on the left-hand side, you're seeing venous plasma glucose. On the right graph, you're seeing immunoreactive insulin. And what they did is they took an oral glucose load, 50 grams of glucose in 400 mils of water, and they had the patients drink this. And then they measured their venous plasma glucose. And that is seen in the orange dots on that left graph. And you can see the nice rise and fall. And then over on the right graph, you can see the corresponding rise in insulin that is secreted based on that oral glucose load, again in the orange dots, and then it falls. Now they took those same patients and they gave them an IV glucose infusion, and they made it isoglycemic. What this means is that they infused glucose to actually match the levels that were seen in the venous plasma after that oral glucose load. And again, they measured the immunoreactive insulin. And what you see here is that insulin level there in the blue dots. Now the difference between those two is termed the incretin effect. So this greater amount of insulin secretion that occurs when you have an oral glucose administration, you get about 50 to 70% more total insulin secreted. It's that is termed the incretin effect. Okay? So let's take a look now at the two incretin hormones. The two incretin hormones are really GLP-1 and GIP. GLP-1 stands for glucagon-like peptide 1, and GIP stands for glucose-dependent insulinotropic polypeptide. GLP-1 has 30 amino acids, and it is secreted from the L cells of the distal ginggium, ileum, and colon. GIP is 42 amino acids, and it's secreted from the K cells of the proximal small intestine. Now, both of these hormones are stimulated by glucose and fat. However, GLP-1 is actually stimulated by neural input. So when you're sitting down for a meal, before you've even taken a bite, your body is already priming to secrete GLP-1. Now, there are some common actions across these two incretin hormones, and that is glucose-stimulated insulin secretion, insulin biosynthesis, beta cell proliferation, inhibition of beta cell apoptosis or death, and fat metabolism in the adipocytes. There are some actions that are distinct to GLP-1, and that is inhibition of glucagon secretion by the alpha cell, delay or slowing of gastric emptying, satiety, and beta cell neogenesis that has been seen in preclinical models. Now, both of these hormones are rather rapidly degraded by the ubiquitous enzyme dipeptidyl peptidase 4, GLP-1 in less than 2 minutes, and GIP in 5 to 7 minutes. Now, it's believed that these hormones may have reduced levels in patients with type 2 diabetes or reduced sensitivity. And there is some debate about, what that is. So now that we've got a quick introduction to these hormones, let's take a look at glucose homeostasis and the role of GLP-1. So before we talk about glucose homeostasis in the fed state, I want to center us on the fasting state. So in the fasting state, glucose is primarily supplied by hepatic glucose production, and this accounts for roughly 85% of the body's glucose needs. Now, often overlooked is the kidney, and the kidney actually provides about 15% of the body's glucose needs through renal glucose production and reabsorption. Now, as we look at the fed state, now things change, because the primary determinant now of plasma glucose is food intake, and more specifically, gastric emptying. So how quickly are nutrients allowed to pass into the small intestine and be absorbed? So what happens in this fed state? Let's take a look at the key hormones in the regulation of glucose homeostasis. So as we said, you've got food intake. GLP-1 is secreted from the L cells, okay? And GLP-1 has immediate actions on the brain, okay, to reduce food intake. So it increases satiety, reducing food intake, and then slowing gastric emptying. These actions are all about slowing the rate of glucose appearance into the plasma. GLP-1 also has effects on the pancreas. In addition to GLP-1 being secreted, though, we've got GIP being secreted from the K cells, and it's also having effects on the beta cell of the pancreas. So these two hormones are impacting the beta cell. The beta cell is secreting insulin. Insulin is stimulating glucose uptake by the tissues, which is leading to glucose disappearance, and insulin is suppressing hepatic glucose production, so reducing the amount of glucose being dumped out there into the plasma. In addition to insulin, we've got the hormone amylin, which is co-secreted from the beta cell, and amylin also acts through the central nervous system to reduce food intake and to slow gastric emptying. Now, GLP-1 also has effects on the alpha cell, and so does amylin. So GLP-1 and amylin both suppress glucagon secretion from the alpha cell. That further reduces hepatic glucose production. And lastly, we've got leptin, which is produced by white adipose cells, and leptin acts through the CNS on the brain to reduce food intake and to suppress glucagon secretion from alpha cells. So glucose homeostasis is actually a finely tuned process that involves multiple hormones and organs. And we have defects in many of these in patients with type 2 diabetes. I want to point out that these actions that I've just discussed are actually glucose dependent. So GLP-1 would not have these actions, for example, to slow gastric emptying if glucose levels were below a certain point. All right? So the actions are glucose dependent here. So in summary, GLP-1 has actions on the stomach. In terms of slowing gastric emptying, it's got actions on the pancreas to stimulate insulin and amylin secretion from the beta cell, to suppress glucagon secretion. We've got indirect effects from the insulin secretion and the glucagon suppression on the hepatic glucose production to reduce it. We've also got insulin driving glucose uptake by the muscle. We've got effects on appetite in the brain, and we've got effects on the heart. Now, Curtis, do you want to speak to, whoops, sorry about that. Do you want to speak to the effects on the heart and the brain?
Yeah, you know, it's really interesting. We're starting to see some of these effects start to kind of trickle out. And, you know, I don't want to get too deep, but I do want to say, you know, the effects on the heart appear to be really interesting on some microcirculation and also some utilization of some of the substrates. So, for example, glucose versus fat, et cetera. And it's some really interesting data that shows that probably the GLP-1s have kind of an underlying common theme of how they work. And because it's a underlying common thing, it kind of speaks not only to the heart but also to the brain. So, for example, I mean, we know that there's a lot of things that go on in diabetes, such as oxidative stress, a lot of inflammation, insulin resistance, and we tend to think of those things as, oh, that's the liver, oh, that's the muscle, oh, that's the fat. But in reality, we're starting to realize that that is not completely true, that other organs, including the heart and the brain, also are affected by these, and they may have insulin resistance as well, and that leads to abnormal processing of metabolites, of everything like that. And GLP-1s, if we look at it at its most basic level, they seem to work by decreasing oxidative stress. They seem to work by decreasing inflammation. They seem to work by improving the organ's ability to function, to move blood, to stop cells from dying, which is very important, of course, in the brain. When we talk about things such as the gut-brain axis for things such as Parkinson's, or even perhaps by Alzheimer's. And so when you think about that, I mean, we're starting to see some really good data coming out. Obviously, the CVOTs speak to the heart, but we also have data now coming out for the brain, saying these all those different mechanisms I just mentioned may be common to some of the neurodegenerative diseases out there. And I know that Bydureon just had a trial a couple of years ago published in the Parkinson's space, and it actually showed that one of the ways they do it in Parkinson's is they put you on the drug and then they take you on and off the Parkinson's drugs, and they see how well you do. And the answer was that it appeared that Bydureon, GLP-1, exenatide-based medications seem to have some kind of disease-modifying effect. So it's a really interesting area. Obviously, we're exploring really hard the CVOT area, and probably the new frontier is figuring out how these drugs benefit people beyond diabetes. But for now, know that, of course, type 2 diabetes patients are at higher risk of Parkinson's and Alzheimer's as well. Back to you, Joe.
Great. Thanks for that update, Curtis. So the question is, we've gone over how GLP-1 works, but what about using GLP-1 receptor agonists for the treatment of type 2 diabetes? So this figure just looks at GLP-1 receptor agonism and notes kind of the main functions that it does in the body, and we've already talked about these, right? Suppressing glucagon secretion, which decreases hepatic glucose output, stimulating glucose-dependent insulin secretion, which improves both the first and second phase insulin response, slowing gastric emptying and decreasing food intake. But the real question, back when incretins were being looked at is, so it does all this stuff in healthy individuals. What does it do in a patient who has type 2 diabetes? Well, that was really answered by Rockman et al. In this rather seminal study. So this is looking at glucose concentration on your y-axis, and it's looking at time of day on the x-axis, going from about 10 p.m. at night through about 4 p.m. the next day. And what they did is they took healthy subjects, about 6 of them, and they gave them a saline infusion, and they measured their glucose overnight and then over breakfast, lunch, and a snack. And you can see, glucose levels are maintained pretty tightly in a nice tight range during the fasting hours. We see a nice spike with the breakfast meal, and then it quickly drops, okay, and then it goes up for lunch and the snack. They did the same thing with patients who had type 2 diabetes, shown in the blue line. They hooked them up to saline, and they followed them. And you can see that now you've got fasting glucose, really around 175. You've got exaggerated swings in glucose after the meals, breakfast, lunch, and the snack. And so you're clearly up at a much higher level. Now, they infused in those same type 2 patients exogenous GLP-1, okay, just to see if this would work. And that is shown in the green line. And what you can see is within a couple of hours, right, fasting plasma glucose has dropped down close to what you see in healthy subjects. More importantly, first and second phase insulin response has now apparently been restored, and we're seeing a much more normal response to meals in these subjects. So this really said, hey, we think that GLP-1 receptor agonism can work in patients with type 2 diabetes. And sure enough, we have many drugs that have now been approved today. And if we take a look broadly at GLP-1 receptor agonists for type 2 diabetes, these are now given subcutaneously or orally. They bind to the native GLP-1 receptor, and they have similar actions as GLP-1. In terms of indications right now for patients with type 2 diabetes, they're indicated to improve glycemic control in addition to diet and exercise. Some of them have indications to reduce MACE in patients with type 2 diabetes and established cardiovascular disease. That would be liraglutide and semaglutide. And just this last Friday, dulaglutide was granted an indication to reduce MACE in patients with type 2 diabetes and established cardiovascular disease, or in patients with multiple cardiovascular risk factors. So we're kind of going beyond that established disease now and looking at those with risk factors. Now, how do all these molecules and all these products differ? Well, they differ by their base molecule. They're either exenatide-based or they're an analog of human GLP-1. They differ in the half-life of the drug and the frequency of the dosing. They also differ by the type of injection device that is used. Broadly speaking, you can kind of group them into two groups. Intermittent GLP-1s, which means they've got a short action, you have to dose them more often. These GLP-1 receptor agonists do not contain a boxed warning on medullary thyroid cancer. The long-acting GLP-1 receptor agonists, however, do contain a boxed warning on medullary thyroid cancer in humans. Now, this is really due to uncertain relevance of preclinical findings, and I want to talk about that. So this is the exact box warning from these long-acting GLP-1s. It says they cause an increased incidence of thyroid C-cell tumors at clinically relevant exposures in rats or mice compared to controls. And it's unknown whether it will cause these thyroid C-cell tumors, including medullary thyroid carcinoma, in humans. So they don't know the human relevance. So why might you see this increase in rodents? Well, it gets down to a very simple fact of physiology. Rodents have GLP-1 receptors on the thyroid. Humans do not. So that's why it's of uncertain relevance. That said, there is a registry that has been ongoing since around 2010, 2011 to look at this, and all of the companies that have long-acting GLP-1s are contributing to this registry. Irrespective, if a patient has a family history of medullary thyroid cancer, or they've got multiple endocrine neoplasia syndrome type 2, you really shouldn't be looking at using a GLP-1 receptor agonist. So let's take a look now at kind of the actions of the intermittent versus the long-acting GLP-1s. So this is a simple table. We've got the organs over on the left. We've kind of got a description of the function there, and we've noted the defect in type 2 diabetes. So in type 2 diabetes, we've got decreased fasting insulin, decreased first and second phase insulin secretion. We've got increased fasting glucagon concentrations. Paradoxically, we've got even more increased postprandial glucagon concentrations. we've got accelerated gastric emptying, and we have increased food intake. Now, GLP-1 is going to address all of these defects. What I want to point out is where the intermittent ones have their strongest effects and where the long-acting ones have their strongest effects. Intermittent GLP-1s really have their strongest effects during the postprandial period. So that's in restoring first and second phase insulin secretion and in suppressing postprandial glucagon concentrations and slowing gastric emptying. They still have effects to reduce food intake, fasting glucagon, and increasing fasting insulin. But primarily, they really work well in that postprandial period. The long-acting GLP-1s really have great effects during the fasting period, so fasting insulin and fasting glucagon concentrations. They still have effects on these other areas, but it's primarily in the fasting state. So that's how these agents might differ. Now let's take a look at the clinical effects, okay, the key clinical effects of the marketed GLP-1s. Now, this is a busy slide, and I'm going to try and speak broadly about the classes. So what you've got over here in the blue, over on the left, are the intermittent acting GLP-1s, exenatide twice a day, okay, and lixisenatide, which is also an exenatide-based molecule, which is given once a day. Then in the orange, you've got all of the long-acting GLP-1s, and they vary from liraglutide, which is given once a day, and oral semaglutide, which is dosed once a day, to exenatide, dulaglutide, and semaglutide, which are all dosed weekly. As you look at these, you can see that, you know, the intermittent acting GLP-1s, they're really reducing A1C from about 0.6 to about 1%. You look at the long-acting GLP-1s, well, now you're seeing more robust reductions around 1% to around 1.7% in that range, okay? So there's a clear difference there in terms of the magnitude of the A1C reduction. When you look at weight loss, you'll notice that it's quite similar across the intermittent and the long-acting. You'd see a bit more weight loss with the long-acting GLP-1s, and the long-acting GLP-1s that really set themselves apart in regards to weight loss are semaglutide and oral semaglutide. So you'll see that you generally see greater weight loss with those agents. Now, the most common side effects are really gastrointestinal in nature. That's nausea, diarrhea, and vomiting. And you can see that these side effects are generally lower with the long-acting GLP-1 receptor agonist. An important point here is it's pretty easy to manage these side effects through titration of the dose. You could definitely see a spike in these side effects as you titrate to a higher dose, but after about 2 to 3 weeks, those side effects tend to diminish. So that, if you're on these things long term, you're not seeing this high incidence of side effects. Now, I want to note that all of these work like a GLP-1, so they are glucose dependent in that they do not cause hypoglycemia unless a patient is taking like a sulfonylurea or is on an insulin. Okay? So, we've got a lot of different GLP-1s out there. I've noted already a couple of differences in indication. Now, if we take a look at, kind of a summary of these GLP-1s, we know that GLP-1 receptor agonists address many of the core defects in patients with type 2 diabetes. As a matter of fact, they address 6 of the 8 in the ominous octet. They have a low risk of hypo when used without an SU or an insulin. They differ in the base molecule, right? Exenatide or human. They differ by half-life. They differ by type of injection device. The intermittent GLP-1s, A1C reduction, 0.6 to 1, primarily postprandial. Long-acting, 1 to 1.7, mostly fasting, okay? And generally, they're pretty well tolerated, with gastrointestinal adverse events being the most frequent and titration being very clear and important in managing the side effect profile. Now, a question you might be asking yourself is, well, wait a minute. Those long-acting, you get this great reduction in A1C. Why would I even use the intermittent acting GLP-1s anymore? So, Curtis from your perspective clinically, is there still a place for the short-acting or intermittent GLP-1s?
Well, I think there is. I think, in clinic, what we have moved more towards daily or weekly products. But one of the things we've really noticed is that there is this subset of patients that do really well on the shorter-acting Bioidas. And in fact, it's not different from when we first got Bioida on the market. Of course, that was the first one on the market. So we learned how to use it very well. And the place that we tend to use it is instead of, so many people are going, and everyone has to use insulin eventually. This is not something I'm telling you that you didn't know. But what happens is that you're on basal insulin, you're optimized. Your next step many times is people are considering basal plus therapy if you're not already on a GLP-1, which we'll discuss a little bit later. But at that point, what it's been shown is that versus adding the rapid-acting insulin, that this has advantages of better postprandial control, less weight gain, in fact, weight loss, and really helping the person to control those postprandials as well. So that's where we still consider the short-acting one. So we consider it, if you're not already on a GLP-1, adding it at that point. Obviously, in the current state of where we're at, we would have to have someone that we did not consider to be at high risk of cardiovascular outcomes or already having cardiovascular disease, because that would push us towards the long-acting preparations.
Great, Curtis. Thanks for that perspective. And absolutely, there's been a number of trials done with Bioida on top of basal insulin, and actually lixisenatide, is looked at on top of Lantus there with their Lixilan product. So that I think you're absolutely right in terms of that place in therapy. And we will talk in a moment about the guidelines, and you'll see when we go over that what Curtis was alluding to in terms of using the long-acting GLP-1s earlier. So we've kind of covered the general clinical effects, and those are the general clinical effects relating to glycemia and weight. But now let's take a look at the actions beyond A1C, their effects on MACE and on renal endpoints. Now, I had the opportunity this last fall of giving an update on cardiovascular outcome trials, and so I'm not going to go through each individual trial here, but rather show meta-analyses across all of the GLP-1 trials. So this was a meta-analysis done by Guglielmo et al. That was published in 2019. In the y-axis, there you've got the trials listed, beginning with Alixa. Now remember, Alixa used Lixi, and you can see in the key over there, I've put kind of a shorthand of the drug name. So this is lixisenatide. This is the only CVOT that's been conducted with an intermittent or short-acting GLP-1 receptor agonist. All the other trials below it are once a week or long-acting GLP-1 receptor agonists. So what you immediately notice is if you kind of take away the yellow line at the top, all of these trials favored GLP-1 receptor agonists, with Leader, Harmony, Rewind, and Sustain 6 all being positive. Okay, Excel falling right on the line. The confidence interval there is right on the line, so it was not positive. Okay, and Pioneer 6, of course, being a small study, and so wide confidence intervals, but certainly the hazard ratio is right down there. When you look overall at all of these trials, including Alixa, you see a risk reduction of about 13% on MACE. Now, the question becomes, well, that's great, but I see lots of types of patients. I see patients who've got established cardiovascular disease. I see patients who've got multiple cardiovascular risk factors. What are the effects in these different patient populations? And Guglielmo also broke out these findings by those patients who had established cardiovascular disease at baseline and those who had multiple risk factors. Now, you'll probably look at this and say, wait a minute, Alixa isn't included here. No, Alixa is not included here because 100% of patients in the Alixa study had acute coronary syndrome, so none of the patients had multiple risk factors. right? So this is looking at those who had established CVD and multiple risk factors. If you look at the upper graph, it looks very much like the overview I just showed you, okay? Leader is right there. Excel now becomes positive, okay? It no longer lands on, so it's positive with this group for established. Rewind looks like it just crosses over, but again, you know, the primary endpoint for Rewind was both of these groups together, not individually. Sustain 6 is still positive. Pioneer 6 still got those wide confidence intervals. And if you look at the overall hazard ratio here, it's really tightened up. It's now 0.86, 14% reduction, and the confidence interval is tightened from what it was before. When you look at patients who had multiple risk factors, however, you know, with the exception of Rewind, I would challenge you to find a study there that has a similar result across those two trials. Really, it's only Rewind right now that shows that they've had an impact in patients who have multiple risk factors. It is worth pointing out that the Rewind was the longest cardiovascular outcome trial where patients tended to be on treatment for 5.4 years. So for a very long period of time. And in Rewind, there was a 12% reduction. Again, very similar to this overall reduction here of 0.86. So it does appear that at least with a long-acting GLP-1 receptor agonist, there certainly is an effect that seems to be fairly robust across this class of agents. Now, let's take a look at the renal composite overview. Now, this is a meta-analysis that was done by Zelniker et al. It was done in 2019 before the Rewind trial broke, and so Rewind is not included in here. However, Rewind did publish a nice paper looking solely at its renal composite endpoint, where it did show that it had fairly nice effects with about a 15% reduction in its renal composite. Now, looking across these trials, the renal composite overview was pulled together as new onset macroalbuminuria, a sustained doubling of serum creatinine, or a 40% decline in eGFR, end-stage kidney disease, or death of renal cause. And what you can see is really, you know, again, treatment favors the GLP-1 receptor agonist in terms of reducing these events, right? And you see kind of an 18% risk reduction overall for this composite. This is nowhere near the 40 to 45% reduction that you will see on a composite like this with the SGLT2 inhibitors, but you know, it is not harming patients, and there is some benefit. Now, they have looked at, okay, what's the main driver of this benefit from in this composite? And it turns out it's really reduction of new onset macroalbuminuria. However, both Excel and Rewind did show a fairly significant reduction in this 40% decline in eGFR as well. So to summarize these MACE and renal endpoints, it looks like reductions in MACE with the long-acting GLP-1s are about 13%. Looks like we've got reductions in renal composites of about 18%. Again, as I said, mostly due to a reduction in macroalbuminuria, although Excel and Rewind have demonstrated nice effects in reduction of eGFR. I've already called out liraglutide and semaglutide. They are indicated to reduce MACE in adults with type 2 diabetes and established cardiovascular disease. And just this past Friday, dulaglutide got the indication to reduce the risk of MACE in adults with type 2 diabetes who have established cardiovascular disease or multiple cardiovascular risk factors. So there is some differentiation there, okay, within the class. Now, you know, as you know, there have been so many cardiovascular outcome trials reading out. It seems like every year we've had one or two reading out, and now we've got a lot of renal trials reading out, and it's dramatically impacted how clinicians and organizations are updating their guidelines. And, you know, Curtis, I just want to get your perspective on all of this data and how it's been influencing guidelines and actually practice.
Well, I mean, it's really been, there's been a lot of interesting development, as you guys know, over the last couple of years in this area. So, of course, when we started, it was mostly just the diabetes folks that were interested in this. So what was happening is that ADA and some of their guidelines started to mention GLP-1s and SGLT2s in the settings of cardiovascular disease or heart failure, renal outcomes, ACE, as well, of course, the endocrinology group in the United States. And then, of course, EASD, of course, at the same time came out with ADA in conjunction. Then, interestingly enough, I think, is that we started to see the cardiology folks really get involved. So AHA, ACC, even the European Society of Cardiology, all of these now are putting these drugs clearly into somewhere in their algorithms. It may be, if this person has type 2 diabetes, consider GLP-1s or SGLT2s. It could be information on heart failure. If they have heart failure, consider an SGLT2 inhibitor. And really, I think, we're moving forward with all the organizations really looking at this, and, this huge area of cardiorenal outcomes has really opened, I think, the eyes. And so, in a weird way, the FDA started all this to make sure that they were safe. And now what we're doing is we're finding that some of these drugs have non-glycemic benefits, and I think that's really important to understand. And the national organizations are recognizing that as well. Back to you, Jim.
Yeah, thanks for that perspective, Chris. Actually, I think it's fantastic that it's actually brought some of these organizations together. For example, ACC and ADA have actually collaborated quite a bit on these, as well as ACE and ACC. So I think we're seeing a lot of different specialties now look at this data. So I think it's an exciting time. So, we've kind of finished discussing effects beyond A1C, looking at MACE and renal. Now I want to shift over and look at GLP-1 receptor agonists and really using them to maximize their effects on body weight. So, as we've talked about, GLP-1 receptor agonists, they activate GLP-1 receptors in the brain, all right? And many of these receptors are involved in appetite regulation as well as calorie intake. Now, higher concentrations of GLP-1 receptor agonists have demonstrated rather substantial weight loss. And the best example for that is liraglutide, 3 milligrams once a day, which was approved for the treatment of obesity. That was Saxenda. Now remember, in type 2 diabetes, the highest dose of liraglutide is 1.8 milligrams. So this is significantly greater, and it certainly has a more profound effect on weight loss. Currently, there are ongoing studies with dulaglutide looking at 3 milligrams and 4.5 in patients with type 2 diabetes who are overweight or obese. Now remember, the high dose for dulaglutide is 1.5 milligrams. So we are doubling and tripling that dose here now, and specifically looking for the effects it might have in patients who are overweight or obese. Likewise, semaglutide is studying a 2.4 milligram dose. Their highest dose in type 2 diabetes that is given sub-Q is 1, and that is being studied in overweight and obese patients. So, a lot of these drugs are looking at their effects, and they're kind of calling out their effects specifically on weight. So it's not just on A1C. A1C, as you increase GLP-1 concentration, the impact on A1C kind of plateaus at a point, but it appears we can go to much higher concentrations to maximize the weight effect. And that's really what is being studied here with these drugs. So if we take a look at liraglutide 3 milligrams or Saxenda and look at that data, what does it look like? Well, it looks like that in terms of mean percent weight loss from baseline at 1 year, patients can pretty much expect 5 to 7.5% of their body weight being lost. If you look at patients who lose greater than 5%, it's really 45 to 62% of patients are going to see greater than 5%. Now, greater than 10% is a little rarer, but it's about a quarter to a third of patients are seeing greater than 10% of their body weight loss. What would you expect in terms of side effects? Well, we've already gone over what those side effects are and we know them fairly well from type 2 diabetes. And it's the same when you look at patients without diabetes or who are obese, looking at these high concentrations. Your side effect profile is generally gastrointestinal in nature. It's nausea, diarrhea, constipation, and vomiting. Now, some people might look at these numbers and say, wait a minute, that doesn't appear that high because, in patients with type 2 diabetes, we were looking at, 20-some percent for diabetes, and this concentration, I mean, I would expect many more. Well, actually, in patients who don't have diabetes, who are just obese, you actually don't see as great of GI side effects as you do in the diabetes trials. So there's a little bit of a difference there. Now, the warnings are pretty much identical to what you have in type 2 diabetes with the addition of suicidal behavior and ideation, okay? Now, how does this compare to the marketed drugs? Well, I shouldn't say the marketed drugs, the other marketed drugs for obesity. And that's really shown on this slide. So there's leukeserin, which is Belviq. We've got phentermine and topiramate, okay, which is glycemia. And we've got naltrexone and bupropion, which is Contrave. I've got a big red X through leukeserin. I'm not sure if any of you caught the news. Curtis was kind enough to point it out to us, but on February 14th, they announced that the FDA had asked the company to withdraw this from the market, and they agreed. So this will no longer be on the market. The reason for this is they had a cardiovascular outcome trial that was ongoing, and the FDA believed that they saw an increase in solid tumors. So that's why that drug is being withdrawn. Now, then we've got, obviously glycemia and Contrave still on the market. So how does liraglutide 3 milligrams compare to these two agents? Well, as you can see in percent weight loss from baseline, quite similar. You might get a little bit more mean weight loss from phentermine and topiramate. You look at the percent of patients losing greater than 5%. Again, very, very similar to liraglutide 3 milligrams. Again, probably a higher percentage there in the phentermine and topiramate, as well as the patients who lose greater than 10% of their body weight. Now, remember, phentermine is an anorectic drug. Topiramate enhances satiety. Naltrexone is an opioid antagonist. Bupropion is an inhibitor of dopamine and norepinephrine reuptake. And so the adverse event profiles that you tend to see in the warnings tend to be a little more CNS related, and sure enough, you can see that as you look down. The bottom line is there are options, and more GLP-1s are actually being studied and will likely enter this space. So, be ready to look at the latest trials with dulaglutide this year at ADA. So, in summary here, we've got type 2 diabetes is a progressive disease. It has worsening of beta cell function, increases in insulin resistance, and result in hyperglycemia. Patients are also characterized by an impaired incretin effect. We've gone through the GLP-1 receptor agonists, and they've been around for a long time. The first one since 2005. The new ones are daily or weekly. We've talked about the cardiovascular outcome trials as well as the impacts on renal, and now we've talked about GLP-1s markedly reducing body weight. And Curtis gave us a bit of a brief on GLP-1s being studied for both Parkinson's disease and Alzheimer's disease. Curtis, we just talked about obesity a bit. How important is it for us to treat obesity? We've talked about these twin epidemics of diabetes and obesity, and they just seem to be increasing. We've got drugs for obesity. Do people really look for a dedicated obesity drug, or are they really looking for a drug that for type 2 diabetes that just has greater weight loss? I mean, what are your views on really the treatment of obesity?
Well, I think that the obesity absolutely is a disease. It's not a personal failing. I think that's one of the big misconceptions we have. But I also think that we are driven, unfortunately, by outside forces that tell us which way we have to push in order to treat. And so I think you'll find most clinicians tend to treat with drugs that help people lose weight because we all understand it's important. It's important for, it really is important for cardiovascular disease, so you have to lose quite a bit of weight for it to have a benefit. You know, it might be important for overall mortality risk long term. We also know that weight loss has potential renal benefits, which is strange, and it's one of those things the kidney doctors like to talk a lot about. We also know it affects triglycerides, so we know that triglycerides now, after you've done some other risk factor reductions, sometimes, you know, there's the drug approved for reducing triglycerides that's on top of other drugs now in the omega-3 space. We know that, of course, things such as blood pressure. So every kilogram you lose lowers your blood pressure 1 millimeter, that's an estimate. So we know that obesity intertwines with all the other cardiovascular risk factors, and some of that, I think, is the reason why when people just say obesity per se, they forget how it intertwines with all these other effects, including ability of people to do the things we want. We always say, oh, well, change your diet and increase activity, but as I talk to all the educators, they know that when people come in and they're morbidly obese, the first thing they tell you is, I walk up a flight of stairs and I'm very tired. So you have to start wherever they're at and move forward. But obesity is one of the central things, I think, if nothing else, that really, really affects quality of life. And, you know, from a standpoint of medical, it's quite clear that it affects and intertwines with all these other cardiovascular risk factors long term. Back to you, Jim.
Great. Thanks, Curtis. In the last couple of minutes, I just want to orient people to the guidelines. So this is the ADA 2020 Standards of Care. I have really just blown up the section that has been enhanced, you know, and talks about indicators of high risk or established atherosclerotic cardiovascular disease, CKD, or heart failure. That's that big red box. And, you know, ADA is now saying, look, after metformin and lifestyle modification, you need to assess patients for these things. And then, independently of baseline A1C or their A1C target, if ASCVD predominates, you need to be treating with a GLP-1 or an SGLT2 with a proven benefit. If heart failure or CKD predominates, the same thing, SGLT2 with a proven benefit or a GLP-1 with these benefits. And then if A1C is above target, going down and treating as you would by adding on other agents. The key here is assessing this early and determining which patients need to go down which pathway. And it's no longer based on just A1C. Now, if the patients don't have indicators of high risk or have established disease, then the ADA says, hey, now you cordon off by if you need to minimize hypo, if you need to minimize weight gain or promote weight loss, or if cost is a major issue. And you can see those pathways laid out here, all right, where the blue arrows between these boxes really represent assessing A1C and intensifying therapy if they're not at goal. The bottom line here is if you're minimizing hypo, you're using agents that are glucose dependent and don't increase the risk for A1C. Weight loss, weight gain, minimizing weight gain, it's SGLT2s or GLP-1. Cost, it's SUs or TZD. This is also, or this big picture view, bringing in atherosclerotic disease, is also reflected in the recent ACE guidelines. This is their algorithm for glycemic management. Obviously, ACE breaks it out a little bit differently. It says, hey, patients who don't have a concurrent or serious illness and who are at low hypo risk, try and get their A1C down below 6.5. If they have a concurrent illness or a serious risk, keep it above 6.5. They go down in their scheme and they kind of cordon it off by, you can see in the middle there, by baseline A1C. If it's less than 7, 7 to 9, or greater than 9, you go to mono, dual, or triple therapy. But in the green box, please note, independent of glycemic control, if established or high ASCVD risk and or chronic kidney disease, they recommend an SGLT2 inhibitor or a long-acting GLP-1 receptor agonist. Under monotherapy, dual, and triple, they actually list the agents in the order that they would like clinicians to use them based on what they believe is the strongest evidence for each agent. And GLP-1s and SGLT2s both have maximal, the highest level of evidence there, okay? And that's why they are recommended right after metformin for mono, dual, or triple. So I'll end there, but I just wanted to bring us back to these guidelines because, you know, Curtis talked about how these have impacted guidelines. We're certainly seeing that. We're certainly seeing these associations working with nephrologists and cardiologists in crafting these guidelines. So with that, we'll see if we have time to take a couple of questions.
Yes, great. Thank you, Jim and Curtis. We will jump right into the questions, and we've got a few in already, so we'll get started. Curtis, the first question. Given that long-acting GLP-1s all seem to have effects on reducing MACE in patients with established cardiovascular disease, how do you decide which one to use?
That's a really good question. So I think one of the things that when we kind of step back from this and we talk about the class and we're thinking about longer acting GLP-1s, you really have to, one, decide, I put it down to if we're getting results from all of this class, it's telling you that now you need to look at other things, such as, you know, clinically and evidence-based wise, we might look at head-to-head trials. We know that there's a difference between daily and weekly. I've always used to think that most of my patients would prefer a weekly over a daily. The answer is you have to ask. So most of my patients do choose a weekly, but I've had a few who say, no, I want to take it daily. If I do it weekly, I'll forget. I think titration is important because one of the things that affects a lot of the people to not be able to continue on therapy, and in the clinical trials, I mean, it's not a lot, but what happens is that I think people in general get to the point where they're kind of balancing. And so those people that tend to not want to continue, there's multiple reasons for that. One of those is GI side effects. So I think you look at the device and you try to decide which one of these is most titratable. And this is my personal opinion. The ones that are most titratable to me are the ones such as the Bydureon, which has the titration built into the mechanism of delivery, liraglutide. The pen is very titratable. You have the doses, but there's a lot of clicks in between the doses. Same thing for the semaglutide. And probably the least titratable is the Trulicity pen. But in general, many people love the Trulicity or dulaglutide because of the fact that it's such an easy pen to use. So I think you balance those different aspects of titratability in ease of use of the pen. And then it comes down to, well, are there huge differences in A1C? The answer is there are differences. But in general, when you start looking closely, you'll see it maybe 0.1 to 0.3, 0.4. It's not going to be your most important driver, but it is important. Weight reduction. In general, you're going to see a little bit of difference between weight reduction. Some of them have really good data showing the higher you stimulate GLP-1 activity in the body, you get more weight loss. And then if that's super important to you, go with one of those. We know that the renal data is coming out with this class. It looks if you have macroalbuminuria, the drugs may help. Obesity, if you have someone who is really trying to help lose weight, this drug is so reinforcing. So one of the things that we really love about this class, even more than SGLT2s, is the reinforcing effect of finally I'm able not to have hunger all the time. And we forget about that in all these CVOTs, but that's such a driving force in some of our patients that it really motivates them to start doing more things. And of course, if you're, there's even data out there for blood pressure reduction if it's high. So I think those are the things that we start looking at, and we kind of mix and match the needs of that particular patient. And bottom line, and this is the truth, is that insurance coverage sometimes drives us to have to use one, even though we may want to use another. Back to you, Megan.
Great. Thank you, Curtis. We'll take one more question. And Jim, I'm going to throw this one to you. And it's asking, what studies are being done on type 1 diabetes and GLPs?
Sure. Yeah, thanks for that question. I think the most robust clinical trial program was probably done by Novo Nordisk, looking at using liraglutide in patients with type 1 diabetes. Now, they have not filed with the FDA, and obviously liraglutide is not indicated for use in patients with type 1 diabetes, but I think they have the most extensive clinical trial data that you could look at if you wanted to look at those effects. In general, in a patient who has type 1 diabetes, they don't have really a beta cell. So the GLP-1 is really acting to slow gastric emptying, right? Reduce food intake, and to suppress glucagon excretion. And glucagon excretion is paradoxically increased in patients with type 1 diabetes. So even though you don't often think of that, that's an important thing to control. And so really those are the areas that a GLP-1 is impacting, and these are areas that are often difficult to control in someone with type 1 diabetes because they're related to the postprandial time or space. In general, with the trials that were conducted with liraglutide, they saw tighter control, okay, in terms of less glucose variability. They saw slight reductions in insulin use. They saw slight weight loss instead of weight gain. So they saw many positive benefits, but I need to stress it is not indicated for use in patients with type 1. Curtis, anything to add there?
No, I think you covered it very well. I mean, I think that in general, the use of the adjunct agents to me are in those, we tend to use them in patients who we have a lot of people in San Antonio where I practice where they may be at type 1, but they unfortunately got some type 2 genes from their parents as well. So what happens is that their insulin needs are going up. They still have type 2 genes, which means they're still insulin resistant. And so sometimes it can help to suppress glucagon and really help with that weight angle that we're talking about in insulin resistance.
Okay,
Perfect,
great.
thanks.
Thank you. Thank you both. We do have to wrap up the webinar, so Jim and Curtis, I want to thank you so much for providing this update today, and I want to thank everyone for participating. Let's see, the webinar was recorded and will be posted on our website, diabeteseducator.org, under the Education dropdown, or at the link that you see on your screen. It will only be available for only 90 days, so make sure you check it out. And don't miss these upcoming webinars in the series. And registration is open for the next webinar on March 18th. Thank you all. This concludes today's presentation.